Just how undemocratic is IPAB? Well, if you listen to IPAB supporters, the board sounds innocuous enough. It's going to be a board of doctors. If Medicare spending rises too quickly, IPAB will make recommendations for restraining spending growth. There's a cap on how much IPAB can cut Medicare spending. If IPAB's proposals will be limited to changes in Medicare payment rates. If Congress doesn't like those proposals, it can issue its own. IPAB cannot affect Medicare coverage or enrollees' access to care. In fact, the law explicitly prohibits IPAB from rationing care or raising taxes or changing Medicare coverage or cost sharing. And IPAB is no different from the Defense-Based Closure and Realignment Commission, which has been fairly successful. Peter Orszag is closer to the truth than most IPAB supporters. He wrote that IPAB has, quote, an enormous amount of potential power, end quote. So much that, quote, Congress saw the board as usurping its power. Orszag also wrote, quote, the default is now switched in a very important way. The default is that IPAB's policies will take effect. And when you actually read the law, you begin to see that Orszag understates the case. Doctors cannot constitute a majority of the board. The statute is explicit about that. IPAB won't be making recommendations, it will be issuing laws. Congress will have very little power to amend or reject those laws. Citizens will have no power to challenge those laws in court. IPAB faces no cap on how much Medicare spending it can cut. Despite those explicit statutory provisions, IPAB will have the power to ration care, to impose taxes, to place conditions on federal grants to states, and to regulate and ration care even for those not enrolled in Medicare programs, so long as IPAB's edicts are related to the Medicare program. All of IPAB's powers will revert to a single individual, the Secretary of Health and Human Services, if the president fails to appoint or the Senate fails to confirm any IPAB members, or if IPAB members cannot agree on a proposal when they're required to issue one. The Patient Protection and Affordable Care Act limits Congress's ability to repeal IPAB to a 7-month window in 2017 and requires a 3/5 majority in both chambers to do it. And if Congress fails to repeal IPAB through that specified procedure, then according to the statute, Congress loses any ability to amend or block IPAB proposals. The Patient Protection and Affordable Care Act literally requires the Secretary to implement all IPAB proposals as written, even if Congress tries to supersede them. Now, what do I mean when I say IPAB will be making laws? With only 3 narrow exceptions, the PPACA requires the Secretary of Health and Human Services to implement all IPAB edicts. Those 3 exceptions are if Congress supersedes an IPAB proposal, if during that 7-month window in 2017, Congress passes a specifically worded resolution to repeal IPAB, or 3, if the growth in national health expenditures exceeds Medicare per capita spending growth, and that can't happen in 2 consecutive years. Unless one of those exceptions holds, IPAB's word is law. There's almost no accountability because the statute severely restricts Congress's ability to block IPAB proposals or to offer a substitute for the proposal. If Congress and the President do not enact a substitute that reaches the same budgetary result as IPAB's proposal, or if they do not waive those rules with a 3/5 majority in the Senate, then IPAB's legislative proposal automatically becomes law. Peter Orszag boasts that Congress and the President will have less power to stop IPAB's proposals than they had to stop BRAC's proposals. Unlike BRAC and executive branch agencies that are subject to the Administrative Procedure Act, IPAB does not need to obtain public input or presidential review of its proposals before they become law. Unlike BRAC, simple congressional disapproval of IPAB proposals is not an option. Unlike with other agencies, IPAB's authorizing statute explicitly bars administrative and judicial review of the Secretary's implementation of IPAB proposals. What about rationing care? Well, the power to change Medicare payment rates is the power to ration care. We've often heard that, well, all that's happening under ObamaCare or with IPAB is they're changing the amount that Medicare pays providers. It's not going to affect beneficiaries. Well, if that's the case, we should just pay providers nothing. If their supply of medical services purely inelastic with respect to price, but of course that's not the case. Now, it is true, so the power to ration care the power to change Medicare payment rates is the power to ration care, but IPAB's powers are not limited to that. It's true. The authorizing statute states that IPAB's proposals, quote, shall not include any recommendation to ration care, raise revenues, or Medicare beneficiary premiums under certain sections of the Social Security Act, increase Medicare beneficiary cost sharing, or otherwise restrict benefits or modify eligibility criteria. These limitations are explicit, they are clear, and they are functionally meaningless. One problem is that the PPACA does not define what the word ration means. It leaves that task to IPAB and shields IPAB's definition from any meaningful review. So if IPAB decides that rationing only occurs when Medicare refuses to cover a given service, it could still deny access to presumably covered services simply by setting Medicare's prices so low that no provider will deliver them. President Obama acknowledged this when he said that IPAB, quote, basically identifies best practices and say, let's use the purchasing power of Medicare and Medicaid to help institutionalize all these good things that we do, end quote. So the whole point is that IPAB decides what practices are best and stops paying for what isn't. But the larger problem is that these prohibitions have no enforcement mechanism. If IPAB issued a proposal that explicitly refused to cover, say, lung volume reduction surgery, or imposed a tax on providers or increased enrollee cost sharing, what's to stop it? If your answer is, well, Congress could block those proposals, then you've just admitted that IPAB can ration care or raise taxes. Because if the mechanism for blocking prohibited proposals is the same as the mechanism for blocking permitted proposals, then there are no prohibited proposals. If your answer is, well, IPAB stepped outside of its statutory authority, so Congress and the courts could block it by stepping outside the statutory rules protecting IPAB proposals, then Congress or the courts could set aside those protections with regard to all IPAB proposals, merely by declaring that in their judgment, an IPAB proposal rations care. Not only would that be manifestly contrary to the statute, but one could even see IPAB still getting away with it. So as surely as IPAB can cut Medicare payment rates, it can deny coverage for specific procedures or raise taxes or increase cost sharing. When Mitt Romney said that IPAB is an unelected board that's going to tell people ultimately what kind of treatments they can have, the Los Angeles Times responded calling it, quote, an erroneous myth debunked consistently by independent fact checkers. Jay Bhattacharya is a prominent health economist and a professor of medicine and economics at Stanford University. He responded, there isn't a single honest, this is a quote, there isn't a single honest health economist out there who agrees with the LA Times on this one.